it looks like it's recording. Okay, so CVAs are also called strokes, right? And it's the leading cause of disability, third leading cause of death in the United States. So anybody remember what the number one cause was? Heart attack, and then cancer, and then stroke. So third leading cause of death. When we classify it, we can give it subgroups. So it's not a stroke is not a stroke. We categorize it. So you can have some that are called global hypoperfusion, or basically it's shock in your head. You're not getting blood flow to the right places. You have ischemia, which means it's because of some kind of embolism. So either it's a thrombotic stroke, which means the clot is thrown, or it's embolic. Like if you're a scuba diver and you go down deep and then you come up, what gas are you worried about pooling in your blood? Nitrogen. And then if you go into a plane, that nitrogen expands even more. So that would cause something like an embolic stroke. Embolic stroke is basically anything that's traveling through your bloodstream that shouldn't be. A lot of fat. If you broke a leg and yellow bone marrow got into the bloodstream, that would cause an embolism. If you had a pocket of gas, if a pregnant woman was injured in the stomach and some amniotic fluid went across the placenta, that would cause an embolism. But if it's thrombotic, then it's a clot they're talking about. And then hemorrhagic means that the blood vessel itself actually broke completely and they're bleeding out in the brain. And the people at highest risk are actually over the age of 65. Stroke has a tendency to run in families. It's genetic. So there are genetic tendencies to it, and it all revolves around their blood vessels. Race has an influence on it. African Americans actually have a higher risk of stroke, but it's not because of the brain. Guess why? Because of hypertension. It's because of the heart. Because their blood pressure is so high, they're pushing all that blood into the brain. The blood vessels in the brain are they're weak. I mean, they're different from the rest of the body. For one thing, what are they lacking? What are the veins lacking in the brain? They don't need valves. They don't need valves, right? Because the flow just comes down. The pathway of the blood vessels, arteries to veins, doesn't match the way it does in the rest of the body. Like, if you look out here, you'll have a radial artery and a radial vein sit pretty much next to each other. In the brain, you don't have the same corresponding artery to vein. So blood circulation through the brain is very different. If you affect what's happening in your blood pressure, you're going to affect your brain. As we age, what have we already said? Your brain starts shrinking, which means there's less tissue supporting those blood vessels, which means they can expand. And if they expand, just think of a water balloon. As it expands, what happens to its walls? They get thinner and thinner until eventually they burst. What do we call if that wall starts bulging out? Let's say a blood vessel wall starts bulging out. What do you call that? An aneurysm. Yep, and then the rupture is when it actually breaks. All right, so we'll talk about different types of stroke. I talked about some risk factors. Age is a big one. Blood pressure is another big one. Smoking is another one because of the way it affects your blood pressure. Okay, so CVAs. And they started talking about this. The thrombotic and embolic stroke fell under which type of stroke on the last slide? Was it the global, was it the ischemic, or was it exactly the ischemic? But it's an ischemic stroke, which means a decrease in blood flow to an area. If you get this situation, let's say you have plaques that are starting to accumulate. So I have these plaques that are accumulating through here. Blood flow starts decreasing. What do you know about all the neurons downstream of this blood flow? Are they going to be able to fire like they usually do? No, going back to the first weeks of class when we talked about any cells, if they're deprived of oxygen, nutrients, or anything, what do they start doing? They don't want to die right away, but they just kind of go into this, like, almost like a hibernation mode, right? They're in this reserve mode where they're trying to stay alive, and what do they do in that mode? They start atrophying, right? They decrease their function, they start shrinking a little bit. So you're decreasing the blood flow, and then eventually, let's say you have a little clot that slides down and plugs that the rest of the way up. What just happens is blood supply to those neurons, they're gone, yeah. So now they're going to die. What's interesting in these little transient ischemic attacks, you'll probably experience these sometime in your lifetime. Well, not you personally, but you'll see them. But these are really interesting. I remember when my grandmother had them. I had no idea what they were, but looking back, I know now. When the blood isn't flowing to an area very well, and you get a little tiny clot that comes through, it'll block off the flow, and you'll see symptoms of that blockage, and what if it breaks free? then suddenly the blood flow is restored, and those neurons start firing again, right? Transient ischemic attacks are telling you that. They're transient, which means they come and go. They're ischemic because there's a lack of blood flow to an area. The transient ischemic attacks are these little things, basically like a mini stroke that doesn't leave residual damage. I remember that she'd always say, man, you know, it's just strange. My whole arm down here feels numb and tingly. And then that would last for a few hours and it was gone. And then she had it like a month later, the same problem. And it started coming more and more frequently. Why did it start happening more frequently? If she started with this blockage, little tiny clots would actually block this up and they clear away. This blockage kept getting bigger and bigger, right? So eventually she had a full-out stroke. Transient ischemic attacks are like warning signs.
That happened like on one actually. She finally had a big stroke, but leading up to that, like I'd get on the phone with her occasionally, and she'd sound like she was drunk, and she didn't drink, but she'd sound like she was drunk. But so, yeah, and afterwards, I don't know how to determine it, but they determined that she had a whole bunch of mistakes.
You're probably asking me, has anything changed over the past, or have you had these type of symptoms?
So
yeah.
I can't see that physically.
What do you mean? If she were in an MRI, you'd see a decrease in blood flow to that area while she was having the transient ischemic attack, but...
You can't see, though, if it's happened in the past. Because I had the impression that they could tell that she had had them in the past.
They probably did that from a history, when they took her history, and they said, because they knew what happened during her stroke, like if she lost, in my grandmother's situation, basically she was kind of partially paralyzed in her arm after the big stroke. She couldn't move very well at all. And they said, were there any warning signs? Did you have numbness or tingling in your arms and stuff like that? And she said, yeah, that's been happening to me for like a year. So that's how they knew it was probably in the past. Yeah, taking history. So thrombotic strokes because the clots build up. And embolic strokes, basically anything else. So you can have a thromboembolism, which is an embolic stroke because of a thrombus. And here you can see the plaques built up, and then whoop, that new piece comes along and clogs it up. Here's an example of how this could happen. So you could actually get a stroke that's happening in your brain that didn't start as a clot in your brain. It starts somewhere else. Like if you have, let's say you have a cancer or a problem that's happening around your lungs. So in the lungs, you get some of this venous return. It's starting to get blocked up. And you get some tension of the cancer over here, or a tumor growing over here. This starts blocking up, but then breaks free, moves downstream. What's going to happen? If it's in the lungs, where does it go next? It goes from a vein, so we'll say it's in a venule. It goes to a vein, which is bigger. Is it going to stick there? Probably not. And then from a vein, it goes into the left atrium, and then from the left, which is bigger than the veins, right? And then left atrium, it goes into the left ventricle, and then where? Up into the aorta, which it could go down your arm. If it went down your arm, what would happen? You could block a blood vessel down here, and it would cause ischemia downstream, which would probably cause that tissue to die. But if it went up to the carotid and into your brain, it could go anywhere and cause that stroke. So typically the clots don't start in the brain, they start somewhere else, like the lungs. And then they move downstream. Here's an example of a blood vessel that's all this fat accumulated. Well, I'll show you this again if I have the heart, but here, if I remember right, this is actually the aorta. We looked at, and somebody has so much blockage, it's like 60% occluded. It makes you want to eat a cheeseburger, doesn't it? What? Oh, you just eat. At least you didn't have fries with it, right? Okay, right. And the three clinical types of thrombotic stroke, you have the transient ischemic attacks, which are basically little tiny clots that are going, but they cause a temporary change and the clot breaks apart. And you're okay. And then when it gets a little bit bigger, they call it stroke and evolution. And stroke and evolution, you see the symptoms start piling on, one after another. So if it's bigger than a TIA, it's blocked something, and now you're seeing like this area. I'm starting to become paralyzed on my arm, and now suddenly I can't move my shoulder, and suddenly I'm feeling this tingling all down my back and everything. It's a stroke and evolution. It's the first sign, the one sign that first numbness, you might want to get to a hospital. Or at least start taking some. Huh?
But that's cerebral too.
Not necessarily. Stroke and evolution, it just keeps symptoms get worse and worse and worse, and if it's not reversed, then yeah, it becomes a completed stroke, which is step 3, or stage 3. But Transient ischemic attacks, they last from a few hours to no more than a day. Stroke and evolution just keeps getting worse and worse and worse until it's a completed stroke. And then hemorrhagic strokes. So hemorrhagic strokes are actually the third most common stroke. They're not as common as the other types of stroke. The TIAs are one of the most common strokes. But the problem here is that with hemorrhagic stroke, they're the third most common, but they're also the most fatal. Why do you think they're the most fatal? What's happening? It's a hemorrhagic stroke. You literally broke the blood vessel, right? With an ischemic stroke, let's say if you had a thrombotic stroke, what could you do to try and reverse that? It's a clot. You take a clot buster, right? So yeah, you get a blood thinner, and it starts breaking that clot apart, and you can recover. But with this situation, what if you thin this person's blood? You had a hemorrhagic stroke, you thin their blood, they're bleeding out more, right? So it's even worse. So hemorrhagic strokes are the most fatal because they're hard to fix or hard to correct. You could give clotting factors, yeah. Okay, and then some of the most common causes, smoking and high blood pressure. So it revolves around the blood pressure again. If you already have weak vessels and your brain's atrophy, it makes the walls of those even less stable. You get this aneurysm, and an aneurysm is just the out pocket. That breakage is actually called a rupture. An aneurysm is just a bulging. The breakage is called a rupture. And then with hemorrhagic strokes, once they think they have them corrected, unfortunately most of them will reoccur within 24 hours to 6 months. It's structural damage. There's something wrong with your blood vessels. And then they have a tendency to cause or be a result of hydrocephalus. So too much water on the brain. Too much pressure in different areas. So if I have tissue back here that's not getting good pressure, the brain's going to think what? Turn the pressure up, right? So now I'm going to risk blowing out in other areas. At the same time, as I turn the pressure up, I get more leakage, which causes more water. So it can be either a cause or an outcome, hydrocephalus. So if a ventricle is swollen and pinching off the blood supplies, the brain thinks the pressure's too low and it raises the blood pressure, which raises more water in the brain. And then edema, another outcome. Either, any of them can be, yeah. A lot of times it has to do with the actual structure of the blood vessels themselves. Like even plaques. Plaques have a tendency to be, if your grandfather had a tendency to build up plaques in his arteries and veins, you probably will too. And the same thing with this. If you have family that has weak arteries and veins, you probably have them too. It's like varicose veins. If a mother has them, guess what? The child's more likely to have them in their ovaries too. Not necessarily absolutely, but more likely to. It's just a sign of weakened walls, blood vessel walls. So if the mother was a smoker, which weakens the walls, a smoker and worked on her feet all day and all of those other things, then the child could avoid those and probably reduce the risks to vascular issues and have a tendency to be hereditary. That's why when you're going to a cardiologist, what the first thing you want to know, or actually for general practitioner when you're giving the health history, what do they want to know? Who in your family died of heart disease, right? It's usually a hereditary problem. All right, next problem, meningitis. So meningitis is talking about what being swollen? The meninges. And there are lots of different types of meningitis. You can have bacterial meningitis, which is obviously bacteria, or you can have aseptic, which is typically viral. So the septic is referring to the bacteria. Aseptic is viral. They also call it non-purulent. Because with aseptic, you don't get all of those white blood vessels that go chasing into the meninges the way you do with bacteria. Bacteria has all those structures on its surface that attract the white blood cells. What does it mean by purulent? Remember when we talked about those different types of fluid? We talked about purulent discharge. It was pus. It was because of that white blood cells in there. So with aseptic, you don't get all those white blood cells in there. And then fungal meningitis, so yeast or a fungus. What's the problem with fungus if that gets around your brain? What's the problem with fungus if it's in your bloodstream in the first place? It's a lot like your cells, so it's hard to kill, right? So if you take an antifungal and you actually have to eat it to kill whatever's in your blood, it usually makes you feel really sick. And then another type would be tubercular, so it's TB, basically. We usually associate TB with what organ? The lungs. But yeah, this stuff it hides inside white blood cells. So it can go all over the place. It gets in your bone, it gets in your muscles, it gets in your brain. So meninges. So these are just different types of meningitis. Alright, let me see. I had a note here. Oh, by the way, meningitis, one of the symptoms that always comes with meningitis, fever. What's another symptom that you usually have? Think of all the swelling back here and the swelling going down. Neck stiffness. Yeah. So common signs are neck stiffness and fever. And then a common form of meningitis is actually from rodent feces. So the next time that you're cleaning mouse poop off the counter because a mouse got in your house, just think if you're aerosolizing that dust, you could be breathing it in, and there's actually a virus in there. Yep. It's a choriomeningitis virus. It's called LCMV. Rodent-borne. A friend of mine, actually, they just rebuilt a house, and we went over to see their house this weekend, and we went to the attic, and there was a baby mouse sitting on the steps, walking around, lost. And when I see an animal that's a wild animal that's close to humans, there's something wrong with this. So there's no way in hell I was touching that thing. No way. I don't have a problem with mice, but I just kept thinking, man, there's got to be something wrong with that mouse. Because there used to be a fox in my backyard during the day, which you don't see a fox near people during the day very often at all. And then when we had it trapped, it was actually a rabid fox. I'm freaked out about wild animals that come around people, but I was just thinking about that. The husband came home that night and removed the mouse and was supposed to take it out in the backyard and let it go. He went out in the backyard and came back about an hour later with $50 worth of cage, walking wheel for the mouse, and now they have a pet mouse called Cheddar. So it's kind of funny. I didn't want to say, yeah, there's probably something wrong with that and you're all going to die. But hey, go off that meningitis, right? Anyway, so next type is encephalitis. Meningitis is swelling of the meninges. What's encephalitis? What's it referring to? In the brain, encephala, right? So in the brain. It's the brain tissue that's swelling. Which is worse, meningitis or brain cells? The brain cells. If you get something in the brain cells and it's destroying the brain cells, do they grow back? Nope. Can you heal the meninges? Yep. So encephalitis, we refer to it as an acute febrile illness because it always causes fevers. I was reading down and saw fibrile, and I was like, fibers? Where'd that come from? And I said it out loud instead of actually keeping it inside. I've lost all internal monologue. So anyway, it's typically viral, which makes it really bad because think about this. It's a virus. What's a virus's job? It goes in your cell and does what? Gets into the DNA, changes the DNA, reproduces, and then kills the cell, right? So if it's encephalitis and it gets in your brain and it destroys all these cells, are they growing back? Nope. So encephalitis is actually worse than meningitis. Meningitis is more easily treated. Encephalitis not. Why else would encephalitis be really hard to treat? Why would it be hard to give them a pill to fix encephalitis? The blood-brain barrier, exactly. So you're trying to attack a virus that gets into the brain, and then the blood-brain barrier is going to be a huge problem there. And then the most common forms, these are always fun too, arthropod-borne viruses. Lobsters and arthropods. You know what kind of arthropods in your house? Maybe? Cockroaches. So yeah, an arthropod's cockroach, it's also lobster, so you've got two extremes there. Something you absolutely don't want, and something that you pay a lot of money to get, right? They're both cockroaches. One's the cockroach of the sea. Think about that next time you're at Red Cockroach. Yeah, I hate Red Lobster. The wife loves it, and I can't stand it. Anyway, and then another one, this is really common too, herpes simplex virus. So the thing that causes mouth sores, cold sores, if that gets up in your brain, it's a virus. It can get into the cells and start destroying it. When I was in at DMU, I had a friend that his mom, she was fine one day, and then one day she just didn't want to get out of bed. She was so tired and exhausted, and later that day she couldn't remember anything. She couldn't remember people's names or anything. We got her to the hospital, and she actually had herpes simplex virus that penetrated up into the brain, and it was going crazy in her brain, causing swelling and inflammation. So when that went away, she regained a lot of those skills, but during the inflammation stages, it was just really bad. They were worried that she wasn't going to make it. So yeah, encephalitis is a lot worse, and it's typically caused by viruses, where meningitis is typically caused by things like bacteria, like TB or fungus even. Okay, encephalitis already done. And then the next group, the tumors. So when you see tumors, tumors are just abnormal growths, cells that are rapidly reproducing, right? So in the brain, what kind of cell would you probably not expect many of to become tumors? Cells that don't reproduce once they're differentiated. Real neurons, right? It's really rare to find a true neuron tumor. So when you hear about a brain tumor, it's typically what kind of cells? Glial cells, yep. So astrocytes, oligodendrocytes. Astrocytes, oligodendrocytes, maybe I have a virus. Syphilis causing memory loss. And then ependymal cells, or microglia, those different types. But if it's called a primary intracerebral, it means it's in the brain, and like I said, they're usually formed of gliomas. It's really kind of rare to have a true neuroma. Well, most of the people who get neuromas are, guess what age group? Very young, yeah. Kids that are like 2 years old or younger. So gliomas, obviously you figured out what an astrocytoma would be. It would be an astrocyte going crazy. Oligodendroglioma. They're just different types. So true brain tumors represent about 2% of all cancers. So they're out there, but the biggest problem is that about 25% of all the brain tumors are asymptomatic. So when somebody dies and they do an autopsy, then they figure out they have a tumor. They had no idea. How could they possibly die with a tumor the size of an orange and not know it? The brain's been compensating. All that time, that thing's slowly been growing. The brain's giving it space, letting it grow, until it actually squeezes or puts pressure on in the wrong place. So if it blocked off a blood vessel eventually, and then the brain's going, hey, you know what? We're not getting pressure up here. Let's crank up the pressure. They had no idea. They didn't have brain trauma or something hit them in the head. But suddenly they had this intracellular or intracranial pressure. So increased intracranial pressure going up and up and up, and they're just getting a headache, they're getting really tired, they're sleepy, they lay down, and they don't wake up. So the bad thing about these tumors is they grow really slow. What's also bad is there any room for expansion? Nope, no room for expansion. Right? And then primary extracerebral means it's not actually in the brain tissue. So oligodendrocytes, those are the things that make what in the brain? Myelin sheath. When you look at something that's outside the real brain, what's the equivalent that's outside the brain? Schwann cell. Yep. So when you see something like a nerve sheath tumor, guess what's making it? It's a Schwann cell. And actually, Joseph, we were talking about this, what's technically in the brain versus out of the brain. You can have a tumor in the skull that's technically an extracerebral tumor. Because you can have that pathway coming, like, for instance, the eye going back to the optic nerve. The optic nerve is technically peripheral, right? Where are the name of the cells that are making the sheath on the optic nerve? The Schwann cells. They're peripheral, right? They're Schwann cells. So if they start replicating and become a tumor, they'll make the same kind of pressure in the brain that is intracerebral caused. So it can be something like a Schwann cell, a nerve sheath tumor that's growing. It can also be a meningioma, which is what's happening. Yeah. It's part of the meninges that's growing inwards. So it can't swell out of the skull either, so it's going to keep compressing down deeper and deeper and deeper. And it'll keep squeezing down. And then the next one, basically metastasized tumor. So things like lung tumors, breast cancer tumors, they have a chance to grow. And this is actually a picture, MRI of a 15-year-old boy that has glioblastoma multiforme, which is an astrocyte tumor. And they call it the great white of tumors because this is a rapidly growing. Astrocytes, those things replicate really quick. So if they become cancer-causing or tumor-causing, they grow really fast. Okay, so the next group, degenerative disorders. There's kind of a common thread between all the neurodegenerative disorders. First is that they're progressive, which means they keep getting worse. Yeah, they just keep getting worse. It may go fast, sometimes and slower at other times, but they're always getting worse. They're long-lasting, so they're chronic, and they leave permanent residual effects. Once they cause the problem, they don't go back. It's like MS. We'll talk about different types of MS. MS, you can have it where it's getting worse, and then it feels like they get better, but in reality, they don't get as good as they were before. They just don't feel as bad as they do today. And then it gets worse again, and then they go back down, but never as good as they were before. So it just keeps getting worse and worse and worse. It's constantly getting worse. Okay. And then a lot of them present as syndromes by the symptoms that you see. Like Alzheimer's, technically with Alzheimer's, we label it by the cognitive changes because we don't actually dig into the brain, take a sample and say, oh, look, there's a plaque that's really Alzheimer's, so you have Alzheimer's. We do it by their physical symptoms or physiological effects. And then with all of these, there's no cure, but there's a lot of research going on. So the first one, Alzheimer's, and you can see an Alzheimer's brain up here. Normally with the brain, you know what these bits are called? These grooves? Starts with an S. The sulci, yep. So the sulci, and then what are the big bumps that come out? There's the G. Gyri. When you look at an Alzheimer's brain, a normal brain, I should put a normal brain up here, but these are all tight. Like back here, see how the sulci are not so pronounced? The gyri, they all squeeze next to each other. That should be like that all the way across the brain. But look at all that space. So you can see with the temporal lobe, it's like hanging down. There's so much gap going through here. And then the frontal lobe and up to the parietal. But which part of the brain is actually not affected very much? So just think of the main four lobes. Frontal, parietal, temporal, occipital. Which one doesn't look like it's changed much? The occipital is pretty intact. So what do you know about their vision? It stays pretty consistent. But it starts typically up here towards the front and moves its way back. So what's to start changing first about them? Personality, and don't forget, short-term memory is controlled by the hippocampus and the frontal lobe. So they start having memory problems. So if you walk into the kitchen, you open a cabinet and look at it and go, oh, why are they coming here? Walk away. It's like you're nervous. I'm kidding, you're probably distracted. It has nothing to do with Alzheimer's. And I say that because most people that have Alzheimer's, who gets worried about them having Alzheimer's? It's family members. They had no clue. Yeah, they're oblivious. I watched this test on a person that had Alzheimer's. It was interesting because they gave her a memory test and they gave a non-Alzheimer's person a memory test. And what was interesting is that this woman said, oh yeah, my memory's great, it's excellent. And then they gave her this thing to remember. They gave her a test on it. She's like, oh, I aced it. She bombed it. Failed. Just completely miserably. Couldn't remember things. But the person that didn't have Alzheimer's, they're like, oh man, I don't think I did so well on the test. I can't remember anything. And they started panicking, like, oh, there's something wrong with me. But the person with Alzheimer's, it's usually their family members that go, maybe we should have her or him checked out. All right, so Alzheimer's, what it is, you can see it's atrophying in the brain. And the reason it's atrophying is not because they don't use it, the not use of an area is an outcome. It's because they get these little plaques that are accumulating, which decreases things like flow, nutrients, excitation of the neurons. And if you don't use it, what happens? I know you all want to say it. You don't use it, you lose it, right? But they start shrinking. They become atrophy. They shrink down. And it typically starts up in the frontal lobe and works its way back. So personality, memory changes, and as it goes back, it's more specific to certain memories. So sound memories, visual memories, all these association areas that are up here helping you connect thoughts. Remembering characteristics about grandma, remember grandma's face, remember their name, all through here. Being able to recall is up in here. So here are some of the changes that your book talks about, so theories. There's no absolute saying this is absolutely the cause. We know in general the big picture is you start accumulating plaques and you start decreasing certain chemicals in your brain. You decrease the function. As an outcome, your brain atrophies, typically starting towards the frontal lobe, moving its way back. And then here's an example of what it looks like. So one of the problems is they get these things called neurofibrillary tangles. If you look inside of a neuron, you've got these fibers running down the axon. They're nice, smooth fibers. And if you ever get into like molecular biology, you can see that there are little carriers that transport things like nutrients back and forth from the axon. It carries neurotransmitters back and forth. But if that's like a railway transporting thing, what happens when you destroy all the tracks? No more transport. So they start losing whatever that neuron was important for. They've lost that function. What if that neuron was a memory-related neuron? What just happened? They forgot the memory. Yeah, they lost that memory. It's gone. Another symptom here, these little amyloid plaques. So the plaques start accumulating. There's a gene in your body that we actually know what it is, but we have a problem shutting it off. But these plaques start sticking together. They start clumping up. So when one neuron tries to talk to another neuron, if that plaque is damaged to synapse, what's going to happen? It'll be like you and me trying to talk and then putting a big wall between us, right? What's going to happen to our communication? It's either turned down or gone completely. And a lot of times you'll hear those referred to as senile plaques. They're the amyloid plaques, also referred to as senile plaques. And then the neurofibrillary tangles are when the neurons get all crunched up in here and that destroys the communication right there. And then you can see the clinical manifestations: forgetfulness, emotional upset. So emotional because the frontal lobe has to do with things like moral reasoning, emotions, etc. And then, like I said before, when we can really say that this person absolutely had Alzheimer's is actually after the deceased, and we look at a piece of tissue in their brain and we can see the plaques. But otherwise, we diagnose them by ruling out other problems with dementia. What was dementia? Having at least 2 cognitive dysfunctions. I want to remember that. So yeah, dementia is having at least 2 cognitive dysfunctions. So forgetfulness and emotional upset. Change in emotional upset could be 2. Confusion and forgetfulness. Emotional upset and confusion. Inability to concentrate. So does dementia always tell you it's Alzheimer's? No, you can have all kinds of dementia. And here's just another picture. We can see the plaques. So you make these little plaques. Your cells make them and they stick up all over the place. So they form sticky plaque and it sticks to the surface of the neuron. The other problem is the neurofibrillary tangles, where you have that neurofiber going through and you start breaking apart and gumbling up. Gumbling. Any word. Gumbling. Gummed and jumble. All in one. Right. And then when you look at the pathways, what's happening is that the cells die, you get the tangles, the plaques, and the communication's bad. And depending on the part of the brain, it can be forgetfulness being the key, but it can also be things like emotion, attention, those things too. And then one of the new theories is that it actually has to do with what's angio mean? Blood vessels. Yep, so they think that there might actually be a blood vessel link. So there might be something wrong with the blood vessels. If you decrease blood flow to a group of neurons and they're misfiring, they may actually produce these wrong, gummy structures, the amyloid plaques. So they're looking at there actually being some kind of blood vessel situation going on. But in either situation, they thought it was the neurons were causing problems with the blood vessel, but it might be the other way around. So amyloid angiopathy, plaques building up around the blood vessel. If you start gumming up around the blood vessels, what's going to happen to the blood flow into the tissue? Goes down. Is that going to help the situation? Nope. It's going to atrophy the tissue even more. Okay, and then the pathology stuff, you look where it's at, cerebral cortex, so is it conscious or subconscious? Yeah, it actually has conscious effects. Their ability to recall, consciously bring out information, to recognize things. The hippocampus, which is associated with what? Short-term memory. Yep, so short-term memory and recall. Also that process of consolidation where you throw your memories in the long term. And the amygdala had to do with what? Emotions, memory, and motivation. Yeah. So their emotions start getting a little bit out of hand. You already know, like the memory. And you don't have to worry about the nucleus and myelin. So the big ones, the main ones, like the cerebral cortex and consciousness, the hippocampus and memory, and amygdala for emotions. Because those are the main keys. And then here's just some examples of dementia problems. So you can take, it's like a buffet. You can take any combination of these. Also, too, they have Alzheimer's dementia. So, being able to focus on specific stimuli, or in other words, attention, storing new memories or retrieving old memories. Delayed gratification, that's part of the frontal lobe's job, to help us be able to postpone pleasure to get whatever we're supposed to do done. Their judgment and reasoning, also frontal lobe. Orientation to time and space. What would be affected if it was language processing? The parts of the brain. Processing. So cortex, again, you want to think of what side of the brain first. Typically the left, that's typically going to be Broca's and Wernicke's, or the space between. So any of these can be parts of the dementia. And then when you look at the progression, so it's slow progression of the gains, so 5 years or more before the big symptoms actually start kicking in. And then it starts with short-term memory and it just gets worse and worse and worse. And then since we know it affects the frontal lobe, the personality can actually change dramatically. And then a lot of times they get more anxiety and depression, and it might be because the amygdala is affected, but if they're living with the situation, they have a problem recalling it, and they know it's going to get worse. They have emotional side problems too. And then death usually comes from infection or from structural changes in the brain. Not because they forgot how to breathe or anything like that. It's because their brain is doing what? It's shrinking, right? So what's it doing to the blood vessels? Makes them more weak, right? So they're weaker blood vessels, so strokes and situations like that. Or because you have all that space around the brain, if you get an infection in it, it's really hard to treat. And then typically the onsets doesn't hit until the 50s. And then if you look, this is kind of interesting, so 6% of people over 65 already have Alzheimer's disease. If you hit 85, you're going to have a 50% chance of having Alzheimer's. Alzheimer's isn't a new disease. What's happening to us? We're living longer. Yeah, so we're seeing more cases of it because we're living longer. And I think I've mentioned this 3 times, that diagnosis is actually by ruling out other problems. To really know definitively, we'd have to do a biopsy, which nobody wants to just pull a section of someone's brain out to test for it. So about 10% actually have some kind of a family link, so some kind of a hereditary link. And we kind of know where that's at, too. We know the gene, the chromosome. But unfortunately, that's like 10% of the cases. The other 90%, we don't really know what's going on. When we talked about Down syndrome, I told you that Down syndrome had a higher risk of AD. So when they've lived beyond 45 years of age, they most likely have Alzheimer's disease. They also have a higher risk of leukemia, remember, and heart disease. Just putting the information from the past back together. And then this is kind of interesting. It's prion stuff. Anybody know what a prion is? It's a protein that's, it's basically like I want to say parasitic protein. It's a protein that when it touches another protein, it changes that other protein, like a zombie. You know what I mean? This zombie bites the next one, which bites the next one. It's this chain of proteins that are affecting one after another, which creates plaques and breakages in communication. So it's just like having those plaques. There are 2 major human forms of prion diseases. There's Creutzfeldt-Jakob disease, and there's something called Kuru. But Kuru usually happens because you ate your dad's brain. It's a whole different ball game. What's the bovine version of this? Mad cow, yeah. Bovine spongiform encephalopathy. Right, and then as far as Alzheimer's treatments, so far everything's been resistant. The only things we've really found is that if you find a way to prevent the plaques from building, then that's the best. But nothing's absolute. There's some interesting links, and I freaked out when I first heard this. So they find that there are higher levels of aluminum inside the brain. So if you eat things that have a lot of aluminum in them, sometimes they have this tendency to stick in the brain and increase the risk of Alzheimer's. I went home and threw out all of my aluminum cans. I was so spooked. Yeah. Yeah, that's another interesting thing. Is if you have arthritis, you have a lower incidence of Alzheimer's disease. So there's something going on with arthritis. It decreases that risk, and we have no idea what it is. It's just so far there's a correlation between the two. So right now the therapy is just on slowing down the progression of the psychological or cognitive symptoms. And then Parkinson's we've talked about before. What's the name of the neurotransmitter involved? Dopamine. What's the name of the spot in the brain? Anybody remember? Substantia nigra. Yep. The substantia nigra is part of a bigger area of the brain that causes muscle inhibition. Do you know what it's called? Basal nuclei or basal ganglia. Yeah. So those are the big things about Parkinson's. And this is actually the doctor that labeled Parkinson's. He didn't create it. I always think that's funny when people say, this is the guy that discovered or invented it. It was always around. He just identified it. So, yeah. Let's burn him! So it's been around for a long time. They used to call it the shaking palsy. He just identified a group of characteristics and said this is what it is. Okay, and then Parkinson's disease. These are actually dopamine neurons that are firing here. And you see some of these Parkinson's, they have a lot less of that dopaminergic activity back in the neurons. There are two groups, and this is interesting too. There are two main subcategories of Parkinson's. There's primary and there's secondary. Primary is typically idiopathic. We don't know where it came from, but it's directly affecting the dopaminergic neurons. We don't know what really caused it. Secondary means we know the cause. It was something, usually it's because of things like brain trauma or toxins that get into the brain. If you ever watched the movie Awakenings, there was post-encephalopathic Parkinsonianism, which was a secondary Parkinson's. That's what Robert De Niro had. He got really sick as a kid because he got bacteria in his brain, which caused inflammation in the brain tissue and gave the Parkinson's-like symptoms. So, secondary Parkinson's. There was a famous boxer that has Parkinson's. You know who he is? Muhammad Ali. And they think he had what? Primary or secondary? Secondary because of all the brain injuries. And then, of course, the famous actor that has Parkinson's. Nobody? Michael J. Fox. Yeah. Anybody know what they think he has? Primary or secondary? Secondary. Originally, they thought it was primary because they thought, geez, where did it come from? But then they looked at his history, and back in the late 80s, early 90s, he was a drug addict. And guess what his drug of choice was? Well, alcohol and cocaine. Guess what neurotransmitter cocaine affects in the brain the most? Dopamine. Right. So they think he burned out his dopamine neurons. And then this was the side view. The last one was a PET scan where you can see it lit up. And so the basal ganglia are the areas down in here, the deeper dark structures. So if you look at it straight on, all these areas through here. And then right as you transition to the brainstem, the substantia nigra is right through here. This is gray substance. And that's full of dopamine neurons. They inhibit excessive movement. They stop you from moving too much. And when those dopamine neurons burn out, then they can't stop the movements, which causes that shaking and that rigid tone. So some of the characteristics to get familiar with, typically it starts after the age of 40, except Michael J. Fox. It happened, I think, in his early 30s was his first signs of diagnosis. 1991, I think, was when it was. I don't remember how old he was. Right. And then the peak age between 58 and 62. In the progression, you can see it takes about 10 to 20 years. It's slowly progressing and getting worse. And it affects men twice as much as women. And then I have that word again, substantia nigra, and that picture we looked at earlier with the two areas. So there's a substantia nigra, there's a substantia nigra. Which one's a healthy person? The big one or the small one? The small one, yeah. So just because it's smaller doesn't mean there's anything wrong with their brain. You can see the substantia nigra is nice and dark. And then all it does is it controls the flow going between the top of the brain and the cortex, down to the cerebellum, and then finally down into the spinal column. We've talked about all these other things before. And then here's just a list of some of the problems. So poor balance and coordination is overstiff. Like I was saying before, when you try and walk across the room stiff-legged and take wide steps, even as I stiffen my leg and stiffen the muscles, it's hard for me to move my whole body because I'm over-tightening those. So it causes balance issues. Slowed movement, which is what? Slow means Brady or hypo, and then what's the movement? Kinesia. Yeah, so bradykinesia or hypokinesia. And then with the rigid muscles, what's that? Overactive, so it's hypertonia. And it's not just their arms and legs, and their face too. So a lot of their facial expressions become very blank or flat, another word they use for it. Right. And then what's really dangerous isn't just the movement, but when you look at the autonomic functions. So autonomics referring to one of what two systems? Sympathetic or parasympathetic. And which one do you think is being affected the most here? Hypotension, sweating, constipation? It's sympathetic. So it plays hell on the sympathetic nervous system. So it responds or doesn't respond at different times. Oh, yeah, I just mentioned that. So here it says the muscle strength is more or less normal. The tone is different, but it's the strength. So it's not like they got Parkinson's and suddenly they start bulking up, right? It's just they're tense. The tension in theirs is high. It's not like they're overexerting power and making the muscle bigger and stronger. It's not quite the same. And then a very small number of cases that they start getting dementia, like Alzheimer's. What's the other disease that they almost always get cases where dementia-type symptoms? That's Huntington's, right? And then Parkinson's itself isn't fatal, but it does shorten the life expectancy due to things like, what are they more likely to do? If their balance is bad, they're more likely to have falls and injuries and things like that. And right now the treatment for Parkinson's not that good. If you ever follow Michael J. Fox, you see they tried stem cells, they tried deep brain stimulation, where they'll put an electrode all the way down into the inhibitory area where dopamine neurons normally fire, and then they try and stimulate to turn down muscles. The problem with that is that when they decrease those muscle firing, what's it going to do to their muscle tone overall? Makes it a little bit weaker. I mean, they're turning it down. So they don't get the shakiness, but they also don't have the strength they usually do. So they're up and down size. Stem cells are trying to put stem cells in the area so they can regrow the dopamine neurons. But the regular legal treatments right now are chemicals like levodopa. And they only give the levodopa when the symptoms become really severe. And there's a reason why. Levodopa gets in your brain, it becomes dopamine. Why don't they just give them dopamine then? Because it can't cross the blood-brain barrier. Yeah, levodopa gets across, you make levodopa in your brain, and it turns into dopamine. They give them levodopa, it crosses the blood-brain barrier, gets into the substantia nigra, and then turns into dopamine. The reason they wait so long is that when you give artificial levodopa, what do you think your brain's thinking? I don't need to make so much, right? So basically what they're doing is they're replacing, as they're supplementing with the levodopa, their brain starts decreasing its own levodopa production even more. So what happens if they go off the levodopa? Do their symptoms come back to the way they were before? They're like worse than they were before, so it's even worse. That's why they wait as long as they possibly can to start giving levodopa. And then another problem with levodopa is that dopamine is not just in the brain. I mean, you give it credit for being a neurotransmitter in the brain, but it's in the spinal cord, it's going into the sympathetic nervous system, the parasympathetic. So taking excessive levodopa causes all of your dopamine neurons to go a little bit up. So the ones that are going to the GI tract, the ones that are going to the heart, things like heart arrhythmias that I use too much. GI hemorrhaging. So it's not just the dopamine going to the brain, it goes everywhere. And then, like I was saying, stem cell disease, or stem cell research to try and keep diseases on the other treatments. And then they've actually tried burning out some of the control areas of the brain, which of course causes more muscle weakness, and you don't grow those back. So it doesn't make them get better, it just decreases the shape. Next one, MS, so multiple sclerosis. And it literally means multiple scarring. What's being destroyed? The myelin sheath. Yep. If you have a lot of myelin sheath on a neuron, what do you know about the signal transmission? It's very fast. Yep. So it's very fast. As you replace that insulator with scar tissue that's not very elastic, not very spongy, but it starts squeezing on the neuron, what's going to happen to that neuron? So before it was big, round, and fatty on the outside, so you get really quick insulated signals, but now it's turning into scar tissue and it's crimping the neuron. What's it going to do? It's going to slowly and eventually stop the conduction of these signals. So that's why they get problems with things like vision, sensations. They get these weird sensations called paresthesias. Because they're getting slow transmission of signals. Slowed movements, if it's going out to the body, if it's an efferent, then they can't move appropriately. So demyelination, and it's replaced with scar tissue. Alright, did I cover everything on this? Oh, what's the name of the cells that's being attacked? If it's myelin sheath, and it's a central nervous system neurodegenerative disorder, it's got to be the oligodendrocytes. If it were a peripheral nervous system disorder, it would be the Schwann cells. Yeah. Which is one of the things that makes it different from Guillain-Barré disease. Which I think I mentioned briefly once before. Do you remember Guillain-Barré? Actually, I think I mentioned in the infection videos, didn't I? But Guillain-Barré affects the Schwann cells. They start doing the same thing, but what's the difference between the oligodendrocyte and the Schwann cell? The Schwann cell can't regenerate. Yep. So with Guillain-Barré, they start going through what looks like MS and high speed. They lose all the same sensations. They have the same problems of vision, everything, so they're basically paralyzed. If you have them on a respirator and you're breathing for them, then after they're over the disorder, then all the myelin starts coming back, and within a year they're walking, talking, and acting almost normal again. Why does MS not do that? Because when the oligodendrocytes get attacked, they don't regenerate. Yeah, so once it's gone, it's gone. Speed's one of the things. Yeah, they could do a test to look for antibodies against Epstein-Barr virus too, and Guillain-Barré. And yeah, speed. MS rarely. With Guillain-Barré, usually it's completely fulfilled within 2 weeks. MS is rarely like that. Okay, and then here's kind of the opposite of Parkinson's, where it's 2-1 more females than males. And it onsets between 20 and 40. It's really rare if you're younger than 15 or older than 50 and getting MS. So aging sucks, but I guess now we just found an upside. Okay, and then the clinical presentation depends on the site, and I think the next slide actually shows you pictures, a scan of the brain. It wasn't the next slide, but I'll skip ahead real quick. So you can see some of the lesions. So they're all over the place. These are definitely visible. You can see them on things like MRIs and CAT scans. But it depends on where the lesions are at, where the body's being attacked. What kind of disorder is that, other than being neurodegenerative, where the body's attacking itself? I mean, it's an autoimmune disorder, too. It's those T cells getting out of control and they're getting into the brain. Should the T cells be in the brain tissue? Nope, the blood-brain barrier keeps the immune system out, except for the microglia. All the white blood cells should not get in the brain tissue. But now they're getting in, they're attacking the myelin sheath. It's not autoimmune disorder. If it's tissue-specific, what type of autoimmune disorder is it? Is it type 1, 2, 3, or 4 of hypersensitivity? It's type 2. Yes. Organ-specific, tissue-specific. Okay, but anyway, there's some of the signs. Depending on where their damage is at, it'll tell you the symptoms. So clinical presentation depends on the site of the lesion. And then the optic nerve is usually one of the first symptoms. Most of the people, when they're diagnosed with MS, their first symptom actually will be something visual. So their eyes have been changing for years and years and years. If it's changing too fast, guess who the first person to send them to a neurologist is? Their optometrist. Yeah, their optometrist goes, wow, your prescription is changing really quick. Maybe you should go get checked out. They go in and then do a diagnosis of MS, if that's the case. Right. And then half the people with optic neuritis are diagnosed with MS. So if you have swelling of the optic nerve, then there's a 50% chance that you have MS. Yeah. So common symptoms, double vision, because if it affects one optic nerve, if it's isolated here, all your life you've been depending on both visual signals coming at the same speed, so that really fast, so that you can get this perspective of the world. But if one signal is slightly slower than the other, then your brain's basically seeing the same visual image twice, which is what? Double vision. Yeah, you're seeing double vision in that situation. The same thing as the signal. When you're going to turn your eyes, they should be turning in perfect sync. If the neurons that are going out to the optic nerve aren't seeing the signals fast enough, one's going to be slightly delayed, which means that they'll get this double vision when they look through the signs. But, like I said, vision is one of the common signs. And then with this, they call it barber chair syndrome. And I've never been able to pronounce that word, so I'm not really going to. But every neurologist that we talk to, they call it barber chair syndrome. Why do they call this barber chair syndrome? Because when you're sitting in a barber chair, women, but you're sitting in a barber chair and you're tilting your head like this so they can stay in the back of your neck. That's when people get these really bad symptoms. Think of it this way: fat. So you have this myelin sheath that's going through the brain down the spinal cord, right? It's nice and squishy and stretchy. You can bend like this and you don't have any problems. But what if it becomes scar tissue? If you bend like this, is it going to stretch as well? No, so as you're trying to pull on that nerve, instead of stretching, it flattens out, it taints the signal, and what's going to happen? You get poor signal. So when people tilt their head like this, they get things called dysesthesia, abnormal pain sensation. What's anesthesia? It removes pain, right? So when you see aesthesias, you're talking about pain sensations. Paresthesias are weird, like paranormal, they're weird things. Weird tingly sensations. Dysesthesias are abnormal pain. So they feel a shooting pain going down their back, or their leg, or their when they tilt their neck forward. That signal's not making it. It's called barber chair syndrome. Probably French, so it's probably medis. Barber chair is what you're going to hear more often. And then this other one is Utah syndrome. Utah is associated with heat. People with MS hate living in Arizona. Why? It's too stinking hot, right? They get exaggerated heat sensations. If you put them in a sauna, they scream bloody murders because it's painful. Put them in a hot bathtub, normally warm for us, comfortable for us, it's unbearable for them. Which is really weird because the further you live away from the equator, the higher your risk of MS. So if you get MS and you move closer to the equator, what's going to happen? You feel like ass, right? You can't handle it because it's too hot and uncomfortable. So the moral of the story is get to Florida now before anything can happen, right? So if you're planning on retiring in Florida, just go there now. Yep. So Utah syndrome is when they get like an extreme sensation of heat or pain because of that warm environment. Okay, and then diagnosing it, you can diagnose it by symptoms and by they can actually see brain lesions. So you can see a bunch of lesions along the top of it. Here you can see this throughout the brain. Here you can see large lumps of tissue. And then the cause is because the T cells are getting into the brain tissue and they're attacking what? The myelin sheath. And what's fun is, do you remember the name of the virus that I told you was responsible for Guillain-Barré? Epstein-Barr. They think there's a huge link to Epstein-Barr with MS too. It's just what part of the body that your immune system should be able to get to is the big difference. Epstein-Barr is kind of nasty. Epstein-Barr had that molecular mimicry where it looks like myelin sheath in your body. It causes mono, it causes Guillain-Barré, the thing is causing MS. It's a nasty little virus. And most of us actually have it inside of us. So about 60% of us will get exposed to Epstein-Barr, but only a small percent will actually get the mono. What kind of people usually get mono? Kissers? People that are under a lot of stress. Yeah, because their immune system's already suppressed because of their stressful environment, and the Epstein-Barr just goes crazy. And then here, just more visual. So you can see the T cells getting in, they're attacking the myelin sheath and destroying it. And here you can see the incidence of more cases as you get further away from the equator. Right, and this one you want to know. So the course of the progression, we name it, there are 4 types of MS in general that you can name. And we name it by its symptoms, how the symptoms progress. So here's one you'll hear the most. You have relapsing or remitting, where they have the MS, they get really bad exacerbations, it gets really intense, and then they feel like it's better again. So we go into this remission, next flat line. Exacerbation, remission, flat line. Exacerbation, remission. Did they ever get as well as they were before the exacerbation? No, it's neurodegenerative. They get these bad symptoms, and when they recover, they're never as good as they were before. They feel better because it sure beats the hell they're going through, but they never actually get as good as they were before. And this is relapsing and remitting. The second type, primary progressive, where it's constantly getting worse. Every day is getting worse than yesterday. And it's like that all the time. And then about 10% actually have severe progressive deterioration. Just keep getting worse and worse and worse. So they're parallel. And then you can mix the two. So here's the secondary progressive. So here you have normal and then exacerbation, remission. Normal exacerbation, remission. Normal exacerbation, remission. And then suddenly something clicks where it just becomes progressive. That works one. And then this one's the road activity. This is progressive relapse. If you look, it's always getting worse, but there are days when it's even worse than that. So it's really, really bad, and then it's really, really bad, and it's getting worse. So they describe it based on how the symptoms hit. Do they get a chance to go through remission, or don't they? Is it always getting worse, or do they have these like flat remission stages? And then it's not the MS that kills them, it's always something else, like brain infections. Like you see on the bottom here, someone died within 7 months of the first symptom because of acute inflammation and infection. Their immune system's getting in, just attacking and causing swelling in the brain in that situation. Okay. So some of the symptoms: increased urinary frequency. Think of it this way. If your bladder fills, when your bladder's full, a signal goes out to say relax. And they let go. If you can't stop it, if you don't have the signal coming down the spinal cord and going out, you can't stop the urination. So urination actually happens more frequently because they can't inhibit it. It's not that they're constantly urinating, it's that they retain water in the bladder, it gets bigger and bigger and bigger. When the bladder says I'm full, it just lets go because they don't have the control coming from the brain going down. Right? And then if they have lesions, depending on where it's at, you can see the effects. Like in the frontal lobe or temporal lobes. Why is the frontal lobe creating things like emotional outbursts? It's where their emotions, moral reasoning, things like that are at. If you saw the MS more in the temporal and parietal lobes, you might look at memory. Right if it were in the occipital lobe, you'd probably have more visual vision. And then the emotional problems, it can be, like we were talking about before, when you had delirium, if you suppress neurons for a while and then they get a chance to fire again, then you get the exact opposite. So you can see unpredictable emotion, depression and delirium and euphoria. And MS really, on average, somebody that has MS versus somebody that doesn't, their lifespan is only about 5 years shorter than the average person. It's usually because of things like infections. MS doesn't really kill them, it's usually something else that kills them. And I mentioned this earlier too, is that suicide rates with people with MS are higher than the average population. And then it can progress so far that if it affects their... I mean, some people can live the whole life with MS and still be able to walk and talk and everything, and just have other symptoms, but some of them, you can actually make them so that they're incapacitated and they end up spending the rest of their life in a wheelchair. Let's see, some people have only one episode, and there are a lot of celebrities out there, it seems like. Montel Williams has MS, but I think he doesn't have any regular symptoms. Anybody know what I'm talking about? Mm-hmm. Yeah, I haven't heard anything. Jamie Foxx has MS too. There are 2 people that have it. And then I mentioned this one. Who? If you're not a president, you're nobody, so I don't know what you're talking about. And then you have to think of just not infections, but also, I mean, people aren't getting around and walking around very well. They're more highly, or have a higher risk of doing what? Falling and damaging their head that we talked about before. And in therapy, there's no cure. A lot of the different treatments are just to slow down the progression. You can't reverse it. So they give them things like interferon, and interferon, remember, turns up the defense of the cells. When we talked about interferon before, it made your virus, right? Your virus warning said, hey, there's a virus in the neighborhood, block the doors, block the windows, protect the cell at all costs. In this situation, interferon is turning up your cell's defense. It's trying to turn it up against your immune system. Why is it trying to turn it up against your own immune system this time? What's causing this? Yes, it's the immune system getting out of control and attacking your body. So it's putting those cells on high defense, saying, hey, you know, the T cells, the Marines may be coming by, and they're not welcome here today. So fight them off. But overall, basically, they're trying to maintain a healthy lifestyle and outlook on things. And then the last section, spinal cord trauma. So almost done here. All right. The next several slides have a lot of pictures on it. But when you look at spinal cord trauma, you want to think about the flow of information here. If I pinch it off, so if I shatter this body and it pumps back, it pinched all those neurons. What's going to happen to communication when we're talking about it? It goes down. Slower communication means that they'll have things like weakness or paralysis. What about their sensations? They may either lose a sensation or have decreased sensations going up and down. Most, and this is kind of key, most vertebral injuries happen to two sections of the vertebra. Can you guess what two sections? Did I put it up there? Nope, should be. Cervical and... So remember, when you look at the sections, you've got cervical, thoracic, lumbar, sacral, and coccyx. So lumbar. Why cervical and lumbar? This is a good educated guess, but no. Actually, it sounded really good. Think about it. What makes the thoracic different than both regions above and below? It has extra support, right? You've got the thoracic cage has the ribs connected to it. You've got all the structures underneath. Look at your neck. Your neck is super susceptible to injury. It's got anywhere you have more mobility, you're more susceptible to injury. Like when you think of joints, what's more likely to get dislocated, your elbow or your shoulder? Elbow goes in one plane. That's all an elbow does, right? The shoulder goes back and forth, up and down, all over. What's more likely to get dislocated? Your shoulder. Same thing. How about the elbow or the hip? The hip. Yeah, it's more flexible again. Anywhere you have more flexibility, you're susceptible to more injury. The neck is extremely vulnerable. The good thing is that we can turn our neck, almost to 90 degrees by 80-some degrees either side. But the bad thing is that it makes it more susceptible to get damage. And the same thing with the lumbar region too. So anywhere you have more mobility, you have higher risk. Guess what sex gets more spinal cord injuries? Male. Guess what age group? The 20s, yeah. So technically it's like 16 to 30, but you know who we're talking about, jackass people. Which I'm sure they're getting up into the 30s. Do they still do that stuff anymore? Oh yeah, that's right. The bearded one died, didn't he? But he, yeah, he wasn't screwing around though, was he? Wasn't it really? Oh, he was? Oh yeah, so that was... The one with big teeth? Steve-O? Is that him? Yeah. And then Johnny Knoxville has a whole different career now, so... Yeah, I was never much of a jackass fan. It was too much like real life for me, so... Anyway. Actually, one of my best friends, Steve-O, he totally could have been on that show. He was such a problem. Anyway, when you think about it, you want to remember the cervical and the lumbar are the ones that are most vulnerable because they get the most motility. So they get the most twisting. You're in a car accident, where do you hurt? You don't usually hurt your thoracics. If you hurt anything, you pop a rib out and the chiropractor puts back in for you. It's more like whiplash or hurting the lower back in an accident. Okay, so those are the most common locations. Here are some of the things that could happen. You can actually get it by hyperextension. You take a blow to the chin, tilt it back, it actually extends these ligaments, rips them, and then you get this compression right here. This is one example. Now that can make you memorize all these, just keeping in mind all the things you could do. Smash the vertebral body. You just stretch the whole spinal cord. You call the leg spine. You stretch the whole thing, you get all these sensations. So you get symptoms probably similar to, what was the name of that disorder I couldn't pronounce? What did they call it in MS? The barber chair syndrome, yeah. Where MIDI? Sure. French. I need some. Anyway, spinal cord injury. I'm kidding. 2 languages I can speak, French and German. Fully worthless to everybody out there except the French and German. And then crushing the body, you can see it in different situations. Depending on where you crush it, you can have other problems. This is why you wear a hard hat, right? You can walk around like a turtle. So if you smash it here, you can stretch it out and you bend your neck forward, or if you smash it completely, you can actually compress it. So it's like mixing elasticized together. Turtle, turtle, turtle. And then there's a torsion. So twisting, and you actually rip the ligaments and you twist the spinal cord, cause the same problems. All right, and then spinal shock. So spinal shock is interesting because wherever you get that initial injury, downstream is either going to be decreased or shut off. So with spinal shock, this is kind of cool. Well, I mean, it sucks if you get it, but when they get it, they lose all the reflexes below the site of the injury, and usually they're paralyzed, right, all the way down. But about a week and a half to 2 weeks later, what's interesting is that if you smack them on the knee, guess what they do? Even if they can't move because they're paralyzed, guess what happens? They get the reflex back. But they don't just get the reflex back, they get something called hyperreflexia. So what's happening? Too far, yeah, it's like an extended reflex. It's the way I justify it in my mind is that reflex it's a natural reflex, but it also kind of listens to the brain. If I smack you on the knee, a signal goes to your brain and comes back down. You know when it's going to happen, so you can suppress that a little bit. When you knock off that signal with the brain, the reflex is kind of like, hey, what's going on there? Something's not happening. What's going on? And then eventually it says, forget it. The brain's not talking. We're going to work on our own. And it comes back, and it's hyperreflexia. It's not just the reflexes that are like kicking reflexes, stretch reflexes. They also get hyperreflexia in the situation of the sympathetic nervous system. If you cut off circulation between the brain and everything downstream, you also cut off the nervous system, like sympathetic and parasympathetic. The sympathetic, what would that be doing for their bladder? It suppresses the bladder, right? So when they're paralyzed, what happens? As soon as the bladder fills, they just let go. So what about, I'm trying to think of another good example. Sweating. Would you expect much sweating down below? Like, if you turn off the sympathetic nervous system, would you expect a lot of sweating down below the level of the injury? Probably not, because sympathetic controls sweating, right? But what's interesting is that a couple weeks after that, these signals find a way to go around, and if you're not getting a response down below, and the brain says, hey, turn on the sympathetic, if it releases it into the bloodstream, will that get down below? Well, hopefully, yeah, as long as you have the body connected down to the blood. But so the blood comes down, what's it going to do? If you have not been sweating very much regularly and suddenly you spurt a lot of adrenaline into your system, guess what those receptors for the adrenaline do? They over-respond. What's going to happen to your heart rate? It's going to go crazy, right? It's going to increase really, really readily. It starts sweating like crazy. It's a hyperreflexia of the sympathetic nervous system as well as normal skeletal reflexes. It's a really strange situation. If they get a little bit of pain or a little bit of fear, guess what happens? They oversweat. Their heart overcompensates, starts beating like crazy. They also become extremely constipated, and they can't urinate either. That's a lot more personal, I feel. All right, some terms: paraplegia, quadriplegia. What's para referring to? A pair, right? So what are more likely to lose? If you have paraplegia, more likely to lose both arms or both legs? Both legs, right? So if you get damage down here, it usually causes paraplegia to the lower limb. If you get damage to the cervical vertebra, let's say that C3 gets knocked out of place and compressed in the spinal cord, what would you probably worry about? Quadriplegia, everything below that, right? So quadriplegia. Plegia and paresis are two different things. Quadriplegia means paralysis. Paresis means weakening. So you could actually have paraparesis, which just means that what's happening to your leg? It's weaker, right? You could have quadriparesis, which means what's happening? All four of your limbs are extremely weak. So paresis versus paraplegia, they're two different things. And one last thing about that. When you have a plegia or paralysis, paralysis' definition is you can't overcome gravity. And this is interesting because some people that have like quadriplegia, if you take them and you suspend them in water, they can move their limbs. Because their limbs don't weigh as much as they did before, and basically they're not having to overcome gravity the way they did, so they can move again. They're still quadriplegic because they can't overcome gravity in a normal situation. Okay, and then I already talked about this autonomic hyperreflexia. So autonomic's talking primarily of the sympathetic nervous system. So uncompensated cardiovascular response to sympathetic stimulation. And then I put the picture in, but we're running out of time, so it's the picture that's in the book, and there's an explanation underneath it. Degenerative disc disorders, so we call them DDDs. In general, the term they use is spondylolysis. It's a general term, kind of all-encompassing term. Spondylolisthesis is actually slippage. I love this term. Right there. Okay. So it's referring to slippage. There's not enough support, so the vertebrae start sliding away from each other. And then what they'll do is they'll actually start fusing like that. So you compress the spinal cord, pinch the spinal cord, and now the spinal cord column is fusing that way. It's the lippage. Get it? Oh, and then spinal stenosis. What does stenosis mean? No matter where it is in the body, what does stenosis mean? It means narrowing or pinching, right? So if you have spinal stenosis, you're narrowing spinal brain, or you're pinching off the spinal nerve. Usually that results in weakness, abnormal sensations, and then eventually paralysis. And a lot of times people get it in the low back. Why do they usually get it in the low back? Why do you usually get the slippage or compression in the low back? Why down here, not so much up here? Yes. All the weight of the upper body is pushing down on here. So if you twist that and you have all that weight, you have a tendency to cause more problems. A herniated disc means this. You have these two sections, right? You have the pulpus and you have the fibrosa around the outside. If the fibrosa breaks or bulges, the nucleus pulposa will actually push out and start compressing. That's the true herniation. Broken out of pocket. So if you go to the chiropractor and say you have a herniated disc, I mean, if you're standing there, you probably don't have a herniated disc. Probably. You actually have something called a sublux, which we'll talk about in the muscles and bone section. Right. And then neurologic complications of AIDS. It's HIV. It gets all over the body. It doesn't have to just be in the white blood cells. It gets everywhere. So HIV, when we look at something like myelopathy, we're talking about it gets into the spinal cord and it affects those muscles. There's motor neurons in the spinal cord. HIV neuropathy gets in the brain, so it's getting into the brain. It's a virus, what we say. What's its job? Getting into cells and changing their DNA. Yeah, and if it changes the DNA and the neurons don't function, they can get symptoms like Alzheimer's, they can get symptoms like Parkinson's, they can get symptoms like any other neurological disorder, MS. If it gets into the meninges, then you have a case of aseptic viral meningitis, like we were talking about before. It's the non-purulent type. Because white blood cells don't go chasing after it. It's non-purulent. And then the worst thing about HIV is that HIV is not actually what kills you. What kills you? Anything else that gets in, right? So the opportunistic infections. Flu, pneumonia, chicken pox, any of those. Right? And neoplasms. What are neoplasms? Tumors or cancers, yeah? So it's a virus getting in trying to change your DNA. If it changes your DNA and causes a mutation that leads to a tumor, that's what's going to happen. We already talked about MS. I don't know why that's in there twice. ALS is the next disease. ALS specifically affects motor neurons. Just motor neurons. Specifically motor neurons. So that's an efferent pathway, the signal going out. It prevents you from doing what? Feeling pain? Question mark? Nope, because that's an afferent pathway. It's a sensory pathway. It prevents you from doing what? Moving. So when you look at this, every time I looked at this, right when I first found it, I thought, man, that doesn't seem right. That normal spinal cord, well, it looks like all raggedy and rough and everything, but the one with ALS is nice and smooth. That's the problem. See all these spinal nerves that are coming on? And how thick and full they are? Well, look at these. They're like absent even in this situation. So they have spinal column, they have the caudate cline, but the spinal nerves that are branching out up here, they're all gone. They've lost the ability to control the movement. And of course, Lou Gehrig's disease, the most famous, or the first famous person to get it was a baseball player, back in the 1920s or 30s. Who's a famous person today that's been living with it for 30-some years? Supposed to be one of the smartest people alive. Yeah, Stephen Hawking. But you want to know that typically people die within 3 to 5 years of diagnosis. The first symptoms are muscle weakness. They might be going to the gym and they're lifting weights, but they just feel like they're getting weaker and weaker and weaker. And they get checked out and they're diagnosed with ALS. It's progressive muscle weakness. What kind of muscles? Cardiac, smooth, or skeletal? Skeletal muscle. So do they die of a heart attack? Do they die because their blood vessels don't dilate or constrict properly? Why do they die? Respiratory muscles. Skeletal muscles that control breathing. They can't control them anymore, and then they suffocate in their own body. What about their brain? Can they think? Yep. So all those inner neurons in there talking between different sides of the brain, they can still think. Stephen Hawking is still thinking. He's still working and writing books, even though he can't move his body at all. So they die because respiratory failure. How long do they usually live after diagnosis? Yeah, about 3 to 5 years. And the cause is idiopathic, huh? I have no idea. Yeah. That's another thing. They're not all the same. There are genetic versions of it, and there are milder versions, but the typical ALS is here about 3 to 5 years, and then they're gone. I know he has like a breathing tube and everything going down his throat too, right? So I'm assuming he moves his chair with his eyes. That's how he speaks with the speak and say thing, right? Because of his eye movement pattern. And here you can see the motor neurons. Normal motor neurons, they go out, they innervate the muscles. Once you move the muscle, stay fit. Here you have this shriveled up or axon atrophy. The muscles are still there. The muscles could function, but they have no neural signal. So it's the motor neurons that are atrophying. And the last couple of them, I guess we only have 3 minutes. Let's see if I have anything to send on a test. Neuropathies are typically associated with pain. There's Guillain-Barré. What was the name of the virus it's associated with? Yeah, Epstein-Barr. What is it symptom-wise? What is Guillain-Barré? It looks like MS. Yeah, it looks like high-speed MS. This is an interesting one. They call this barrel man syndrome, or man in the barrel syndrome, because it looks like somebody put a barrel around his body. He has extreme weakness in the arms. What's interesting about this is that if your arms had no control, they just hang closer to your body. By you standing like this, you're actually holding tone in your muscles to keep them out just a little bit. But when you completely lose that tone, it's called brachial amyotrophic dysplasia, which means brachial telling you arms. Amyotrophic means without muscle nurturing, and then dysplasia. 2, what's wrong with it? Is that paresis? It's not weakness, it's actually paralysis, yeah. So he has paralysis here and he can't move his arm. It looks like somebody slid a barrel over him. That's why they call it a man in barrel syndrome. Let's see, we don't need to go into the radiculopathies. This one you do need to know, but I think we talked about it before. Myasthenia gravis. It's an autoimmune disease. And the body attacks the little tiny receptors for what neurotransmitters? For muscle contraction. Acetylcholine. Yep. So the body attacks the little receptors for acetylcholine. They're still making acetylcholine, but it's not working because it's being broken down faster than they can actually bind to the only good receptors they have. So how they treat that is they'll actually give them a chemical that stops the acetylcholine from being broken down. So when they release it, more acetylcholine stays in the synapse. Kind of an interesting disorder. But the first signs of it are muscle weakness in small muscle groups, like the eyes. Ptosis, they get drooping of one eye. So little weak muscle group, and it's not getting enough acetylcholine, so it has droopage. They can't contract and keep it open. And then the muscle that control movement of the eye, so one eye will actually move better than the other one. What's that going to cause if they're both not working the same? Yeah. So double vision. They start actually having double vision because as they're looking side to side, one eye's not keeping up. So diplopia. Opia, you always want to think of the eye. Diamond, double vision. And then when it gets bad, they take more of these anti-acetylcholine esterases, but if it gets too bad, they can't swallow efficiently, so food can get stuck in their throat. What other muscles might you have to worry about if it gets too bad? What other types, or what other skeletal muscles? Yeah, respiratory. And it looks like it's exactly 4 o'clock, so I'm not going to make you go through all the types of myasthenia gravis, just know the general idea.